I'm not the house of cards that falls down easily. Ooh, I'm strong enough to handle what you throw at me.
Welcome to Mental Health News Radio. I'm your host, Kristen Sunanta Walker. Just what are we going to discuss? The intimacy that is mental health. Let's continue to make it as comfortable as discussing brain health or heart health. This show has been on the air for several years, and we have amazing co-hosts. And then we created a network of podcasters on mentalhealthnewsradionetwork.com, a place where every possible facet of mental well-being can be talked about openly. My show, after several hundred interviews, the format is this: intimate, deep, funny, touching, sometimes uncomfortable, but always vulnerable conversations with interesting people. The goal is to have you, our listening family, many of you who have become my good friends, feel as though you are listening in on private conversations. Thank you for tuning in and becoming part of this amazing journey with me, and now with our network of podcasters. Just knowing this podcast might be helping any of you realize you are not alone on this journey called being a human being makes doing this podcast worth every second.
After all we promised, we'd be cordial.
Hi, everyone. This is Kristen Sunanta Walker, your host of Mental Health News Radio, and I'm here with Dr. Steve Levine. Steve, thank you so much for coming on the show.
Thanks for having me, Kristen.
Now, I love this. I know we're going to talk about a lot of different things, but I love the fact that we're going to talk about ketamine. You are a board-certified psychiatrist and psychopharmacologist, and that's, say that word 3 times fast, but we have not talked about the use of ketamine in terms of treatment for depression on my show, and I've been on the air for 4 years, so when I saw your information come across my my desk, so to speak, which isn't really reality anymore. Who looks at things on their desk across my computer screen? I went, we need to talk about that. We'll talk about other things too, but before we get into that, why don't you tell our listeners just a little bit about yourself and your background?
Great, thank you. So, as you said, I'm a board-certified psychiatrist. Going a bit further back in my background, I'm a psychiatrist who didn't plan to be one. Mm-hmm. I went to medical school planning to be a surgeon. And in medical school, I went through my surgery rotations. I enjoyed the procedural aspect of it. But I pretty quickly realized that surgeons weren't my people. And, it had a lot to do with what was the primary focus of the doctors I was working with. And with surgeons, it really seemed more of a competitive element. With the primary medical specialists, it seemed much more disease-focused. And to me, I don't know, being primarily interested in the disease, there's some hubris in that because it pretends that we know more than we really do at this point. And, that body of knowledge is always changing. But some mentors that I had who were psychiatrists, it seemed that what was most important to them and what really kept them engaged was the fact that everybody has a different experience of life. Everyone has a different story. And they were most interested in that human element and that attachment to that path through life. And so I took a bit of a leap, not necessarily knowing exactly what psychiatrists do on a daily basis, and wound up really finding a home for myself. Mm-hmm. And very different than spending my time treating people with intravenous ketamine. The focus of my training really was pretty traditional, and that was as a therapist first. And so when I started off in private practice about a decade ago, that's really how I was spending most of my time. However, part of my background was really being disillusioned with the menu of options that we have as far as pharmacologic options, medication options for things like depression and related conditions. Because while they clearly work and they've clearly helped a lot of people, most of them are pretty similar to each other. Most medicines are developed based upon the same hypothesis of depression, which is flawed in many ways. And because of that, likely, it leaves many people untreated. And so with that background dissatisfaction, I'll shut up here in a minute because I've been droning on.
Oh,
but it kind of it set the table for me to be interested in what else do we got.
Yeah, because there are people that are resistant to medication, and this is definitely an alternative. I don't know much about it, but as I was saying before we went on the air, that Dr. John Huber with Mainstream Mental Health, he's one of our podcasters, he is considering using this in his practice and at the hospitals where he works. So obviously it's a treatment that is successful. In how have you found it to be successful, especially in a patient that's tried every medication in the book and then boom, this is the thing, that works for them? What's the difference between those two realms?
That's what really got me interested in using ketamine in the first place. It was an observation of doing a second opinion consultation with somebody who had tried absolutely everything under the sun and either had no response or had intolerable side effects that made it difficult for her to continue with treatment. And so to back up for a moment and just because some people may not be familiar with what ketamine is at all, just to give a little bit of the history of ketamine and why we're even talking about this. Ketamine is a really old medicine. It's fully synthetic, it's fully man-made, and it was first developed back in 1962 to be used as a general anesthetic, so for anesthesia during surgery. And this was not one of those accidental findings. This was developed very much on purpose in a very thoughtful way. The idea was that most anesthetics, the way that they work and the reason why they can be given to you and you can then go to sleep and have a painful procedure like surgery is because they reduce all of your vital function. They lower your drive to breathe, they lower your heart rate, your blood pressure, and because of all that, it requires an anesthesiologist and very controlled conditions like the surgical suite. But there was an interest in developing an anesthetic that was much safer than that and didn't require such carefully controlled conditions. The only thing that existed at that point really was phencyclidine, which is also known as PCP or angel dust.
Right.
And that has obvious limitations.
Right.
And so a scientist named Calvin Stevens was working for Park Davis in Michigan, and he developed this compound ketamine, and it was, as I said, quite different than other anesthetics at that point. And it really proved itself during the Vietnam War. It was FDA approved for human use in 1970, and then it cut its teeth during the Vietnam War, where it was known as the buddy drug, because it was considered so safe that your relatively untrained buddy, under uncontrolled conditions on the battlefield, could administer this to you for treating acute trauma and acute pain, and actually the soldiers, after receiving ketamine, could even assist in their own evacuation. So a pretty unique and special medicine in that way.
Right.
And as of the early 70s, there were already some hints that ketamine in much lower doses, and doses that are much lower than you would use for surgery, had some antidepressant properties. But it wasn't until the mid-90s when John Crystal and a couple of others, including Dennis Charney, were doing research at Yale. And they were, investigating many aspects of ketamine's mechanism. And they wound up doing a study with a population of folks who were quite ill. They had depression, severe chronic depression for many years. They had tried many, many, many medicines. This was a group of people who never get included in depression research because the researchers would expect that they would never respond to anything. And despite that, these folks were getting significantly better. They had at least a 50% reduction in their symptoms after a single exposure to a very low dose of ketamine. And nobody believed it because we didn't have any other example of a medicine that worked in this way for depression. And so 6 years went by. This was in 2000. 6 years went by before the next study came out. 4 years went by for the study to come after that. But at that point, the pace really picked up, and there's been a slew of studies at this point, and all of them have reproduced and replicated these very rapid acting effects, even in highly treatment refractory folks. And so the personal story for me was, I mentioned I was doing this second opinion consultation for somebody in 2010. She hadn't responded to anything. But what she wound her way around to somewhat guiltily admitting to me was that the one thing that seemed to help her was taking cough medicine. And amongst the different cough medicines she tried, the common ingredient was dextromethorphan, the cough suppressant. And that made me really curious. What is it about dextromethorphan that could explain her observation? And then further from that, is there anything else out there that's already available that shares any properties with dextromethorphan and has any research to support its use in depression? And lo and behold, there were a few medicines that fit those criteria. But it brought my attention back to these early papers on the use of ketamine for depression. And my reaction was, wait a second. This is a 50-year-old medicine developed in the first place for its safety that in fractional doses is producing significant effects for highly treatment-resistant patients who are at extremely high risk for suicide, not to mention the ongoing risks of untreated depression. Why wouldn't we think about using this?
Right.
And that was me.
Now there's feedback that, that comes through. I know anything, that comes out of the media at times can be, to get a headline, they'll talk about it being the horse tranquilizer and things like that. So how do you allay people's, nervousness around things like that, and their reticence about using this, even though it's been around for a long time?
Yes, it's a good point. And some fears we should allay, and some we should take seriously and have a discussion about. And so you're right. There always are these, very grabby headlines associated with ketamine. And we can talk about why that may be the case. And some of it's unfortunate because it might turn people off to what could be a very good option for them. But you see things like horse tranquilizer, cat tranquilizer, right, rave drug, addictive drug, things like that. So on the allaying people's fear side, let's talk about horse tranquilizer and cat tranquilizer. Well, not really tranquilizer, but anesthetic. And yes, it's used in animals as well as people. And the reason why it is used in animals as well as people is because it's a good anesthetic.
Right.
And many medicines that are used in people are also used in animals. And so, it sounds funny to some people, or it's a grabby headline, but there's not much there. It is a medicine like many that are used both in people and in animals.
Right.
As far as its reputation for being used in club settings, as a rave drug, as a drug of abuse, yes, there is some abuse potential for ketamine. And in some parts of the world, it's a big problem. Many people abuse the medicine. That to me says a lot about the idea that, well, almost any medicine has some potential to do harm. And I think in some cases it can be helpful when there are known harms associated with a medicine, and so that way we're careful with it from the beginning, as opposed to being very cavalier and just assuming something is safe and handing it out like water.
Right.
And it says a lot about intention and mindset and setting. Any medicine any drug that has some abuse potential, the mindset that somebody is in when they take it and the setting in which it's taken have a lot to do with whether it's abused or other people become dependent upon it.
Right. Look at our current opioid crisis.
Exactly. Yeah. A big part of the opioid crisis, well, two main things. Number one, opioids are highly psychologically and physically addictive. And number two, it's access. Somebody has a dental procedure and then they're given a 30-day supply of medicine, but they only need 2 days worth for acute pain, but now it's sitting around. There's a decent chance that somebody's going to take it now just because they want to feel the other effects of it, and that's a setup for abuse and for addiction.
Right.
In the case of ketamine, it is actually not physically addictive, and it's fairly weakly psychologically addictive. But the main point is access. And I'm somebody who feels strongly that ketamine is a medicine, especially given the current opioid crisis, that should only be given, at least right now, in a controlled medical setting. And when it's the case that somebody is coming in with the intention of treating severe depression, it's being given in a controlled medical setting, and they don't have access to it outside of that setting, the risk of abuse is extremely low.
Let's talk, just because there are a lot of people that are my listeners that know I'm in the business side of mental health as well. So let's talk a little bit about how particular insurance companies are in terms of covering this kind of treatment.
That's evolving, and in a positive way.
Good.
When I first started treating patients in about 2011, from the beginning, most of my patients have gotten some reimbursement from their insurance company. And the reason why is because I'm a psychiatrist, and now that we have 10 locations now, but every location is run by a psychiatrist. A lot more happens within a visit than just giving somebody ketamine. The psychiatrist spends about 45 minutes each session with the patient. There's a review of the other medications they're taking. There's a lot else that happens, like I said, other than just giving somebody ketamine. And so we're able to give somebody a receipt for the visit that reflects that. And if they have out-of-network benefits, they can submit a claim and they get reimbursed.
Gotcha.
There are some other practices that are run by anesthesiologists or emergency medicine physicians or family physicians. They aren't able to do that, and so typically it is fully out of pocket. But what I'm more interested in is direct coverage. And we're starting to see some breakthrough there. For example, Kaiser Permanente, which is a very interesting system because they're a closed system. They're the insurer, they're the quality assurance, the provider, they're everything. And so they have the opportunity just to decide what to make available to their members based upon what's most effective and also what's cost effective for them. And they now offer ketamine, intravenous ketamine, to their members in 8 locations in Northern California.
Mm-hmm. Okay. Well, when a place like Kaiser starts putting the stamp of approval on this, others will follow.
Exactly. It's a big deal. Some other examples, Yale University, they have their own ketamine clinic. They've negotiated contracts with 2 insurers for direct coverage. So there, in spotty ways, there already are examples of direct coverage, and we're trying to move that further along.
Wonderful. So how long, and tell our listeners actually about your practice. You've got multiple locations, and it's very different. We have a guest that comes on regularly, Dr. Paul Meyer. He has 14 behavioral health nonprofits around the United States, and it's very different. And he's also a psychiatrist, but he getting that perspective of someone who is a practicing psychiatrist or counselor, and they also run the ship is a very unique perspective, because you do have to have your foot in both worlds. So first, tell us about your practices, and then why are you okay with manning a ship like this?
Well, let's see. So we originally were called Ketamine Treatment Centers, a name that I never liked, but chose intentionally. I needed a very descriptive name back in 2011, because at that point, really most people were not aware of ketamine as an option for treating depression, and those who were would be looking for it by name. About 6 months ago, we changed our name to Actify Neurotherapies, and that was for a number of reasons. Number one, I've never thought of us as a ketamine clinic per se, because to me that's quite limiting. Because I don't see ketamine as a magic bullet or the end-all be-all. I see it as a tool, and one of hopefully many new options that's coming down the pike. And actually, one of the legacies of ketamine longer term, it remains to be seen what ketamine's legacy specific to that medicine itself will be, but what one will certainly be is the one that's lit a fire under pharma's butt to be willing to take risks again with innovating with novel mechanisms. And many of the products in the pipeline right now are based upon ketamine's mechanism. And so, we take the position that right now ketamine is a relatively unique option as a rapid-acting antidepressant, and one that doesn't need to be taken on a daily basis. However, we're also committed to not just delivering ketamine, but staying on the leading edge of what is evidence-based and safe and effective and most thoughtful in trying to address an unmet need in treatment-resistant depression. And so, yes, we have 10 locations around the country now operating under the name Actify Neurotherapies. We, in addition to ketamine, are also starting to offer TMS, which is transcranial magnetic stimulation.
Yes.
And we'll be rolling out some other options in the not too distant future with the aim of being more of a diversified option, again, for treatment-resistant depression.
Have you ever heard of the Fisher-Wallace stimulator?
Yes, I'm quite familiar with that.
Okay.
And so, in Fisher-Wallace, the stimulator, another example of neuromodulation, of which TMS is another. ECT being the oldest and best known example of that.
Right. We actually interviewed Chip, the CEO of Fisher-Wallace, not too long ago. So, and I bought the device for myself because I won't recommend it out into the as a potential sponsor for our show or for our network, and I won't do that. Have someone become a sponsor unless I'm using it myself.
Yeah, great. And, the Fisher-Wallace device is interesting. It's an example of CES, as I'm sure you're aware now, cranial electrotherapy stimulation. Mm-hmm. And one of it leads to neuromodulation options. That's interesting to me right now because it kind of democratizes neuromodulation in the sense that they are relatively inexpensive, safe, and easy to use at home devices. Another one being TDCS, transcranial direct current stimulation, which has some great research behind it.
Well, what I love is that you're using other modalities because SSRIs are not the only thing out there, and there are many side effects that just make it so that it's unbearable for some people, and for other people it saved their lives. So but let's step into the business side now. What made you want to, step into having your feet in the business world, being an owner, and then also being someone who's actively practicing as well?
Yeah. So one way I tend to answer that question is to quote one of my favorite books. There's a book by Kurt Vonnegut called The Sirens of Titan. Mm-hmm. And in this book, the main character winds up traveling around through space and time through this convoluted mechanism. And he arrives in the future to a waiting crowd, and they want to know how he got there. And his answer to their delight was, I was a victim of a series of accidents, as are we all. So my way of saying that my path has very much been unintentional. I was not in the cradle wanting to be a psychiatrist. I was not in the cradle wanting to treat people with ketamine. I did not originally have the intent of running a business along with being a doctor, but it's where my path has taken me. And, some of it was, I told you the story of originally getting interested in ketamine. Once it made sense to me, once I had this reaction of how could we not think about using this, right, then I couldn't talk myself into not doing it. It just made sense, and I couldn't not do it at that point. And then as I gained more and more experience with treating people directly with ketamine, and I was seeing just amazing results, and in some ways it was the apology to the former version of myself that planned to be a surgeon, because in some ways it is a more surgical approach than talk therapy or SSRIs, because you're expecting, a much more rapid response. Then, it was hard to stop there. It was hard not to look around and say, wait a second, so this is helping a lot of people, but it's not available. People are having to travel from across the country or from around the world to come to Princeton, New Jersey, which is where I'm based and I had my first clinic. They're having to travel all this way to have this treatment, and that's absurd. And it was around the same time that I read a book called The E-Myth Revisited, so the second version of a classic business book called The E-Myth. And the central premise of that is that you can't simultaneously be the entrepreneur, the manager, and the tech. And so I realized that if I wanted to make this more available, I would have to pull back a bit clinically. I still do some clinical work, but I would have to pull back a bit clinically and really focus on being the best business person I could be. Something that one of my colleagues has always says, he's our chief operating officer, Kyle Snook. He says that if you ask me if I need air or water, I'm going to tell you that I need both.
Right.
and so as it relates to our practice, our company, Actify Neurotherapies, do we have to be the best clinical practice in the world, or do we have to be a good business? Well, we have to be both.
Right.
Because if we fall down on either one, then we can't do anybody any good.
So very true. So very true. And it's kind of like this. I always knew as a child that I was going to be the owner of my own business. I had no idea what that business was going to be. I had no designs on, I want to run that kind of a business or that kind of a business. I just knew that I would be the owner.
That's very interesting.
And that happened. And then I had no idea that I would be running, a podcast network either. That just became that kind of like the Kurt Vonnegut story. It just kind of evolved into what it is. But it's interesting.
You're a victim of a series of accidents, as are we all.
Absolutely. Absolutely. And thankfully, they're ones that I enjoy. So that's a good thing. And getting the message out, about our entire goal is eradicating the stigma around mental illness and around those two words, mental health. There's still some, pushback from people when they hear the term mental health, and yet you could talk about brain health and they'd say, oh, well, let's talk about that. And there'd be no, ooh, that's a touchy, So,
I have opinions about that, but why do you think that is?
Well, I think that mental scares people. It feels like it's something that's out of their control. And I think that there's been so much disservice done by movies, social media, everything in terms of anyone having a mental health problem that it's been blown so way beyond what's acceptable in terms of explaining something that people are terrified of it. They're terrified of being associated with that when everyone at some point in their life has some kind of a mental health struggle.
Yeah, I think that's got to be a big part of it. I fully agree. In some ways, it is ubiquitous. It's so much more common than any other health difficulty that somebody could deal with.
Absolutely.
And so I don't think there's a single person out there who hasn't either personally or has a close first-degree relationship that has struggled in some way at some point with mental health. And I think that causes people to really want to put their hands up and distance themselves from it. And it's really unfortunate that something that everybody can relate to, so many people disavow.
Well, think about it too. I mean, what is it that we're talking about? We're talking about the words mental health. That doesn't mean anything other than just mental health. It does not mean mental illness, or it just means mental health. And what's interesting to me is, what are things that force you to go into business for yourself, or that took you away from being a surgeon to doing what you do now? Probably some discomfort and pain, or something in your life that made the decision to become a surgeon not part of your trajectory, and you go on to this other trajectory. That was a symptom of your mental health at the time. And when we struggle with it, it can push us towards the greatest things that we do in life. So it's really interesting, the spin that gets taken on it, when really it's very much like that seed that gets planted and has to explode in order to reach its full potential. That's all that we're talking about with mental health, and yet such a negative stigma is still associated with it.
I couldn't agree more. And another aspect of it that's really absurd to me is that it pretends that the brain bone isn't connected to the neck bone, which isn't connected to the belly bone and the rest of the body.
Exactly. That's what I try to tell people, even when they come on. I've had some really, quote unquote famous or, celebrities in the mental health world. And in and out of it, and just say, well, those other people that have mental health problems. And I'm like, what do you mean those other people? Everybody. If you were uncomfortable at one point, and when you were a teenager and you struggled with your self-image, you were having a mental health episode or experience, whatever you want to call it, at that time. So that qualifies you as part of the other.
Exactly.
So yeah, it's fascinating to me. But your thoughts, because you said you had your own ideas around, why there's stigma associated. What are your thoughts around that? You're the guest. So.
Well, but it's also why I love people, right? Because we're all rather silly, right? But we're I think forced in some ways to take ourselves quite seriously, and there's this myth of growing up, that demarcation of now I'm an adult and I'm supposed to have it figured out, and I'm supposed to have fixed, firm opinions of who I am and what the world is, and a philosophy of life. And to really push away from any ideas of struggle.
Right.
But I don't think that's the case.
It's not. How would some of our greatest inventions, how many times did, let's say, Abraham Lincoln fail before he became a quote unquote success? And struggled with depression right along through it. There are just so many stories. I still don't completely understand the scaredness around it. But I think the only thing that I can come up with is that it leads to a lack of control. And that's what scares people, that they feel like it's because it's your mind that it's scary, because if there's something wrong with your mind, that does affect every other part of your life and your body and so on. You can have a psoriasis, or you can have a bunion issue, and that doesn't necessarily affect everything else going on in your life, but mental health does.
Yeah, I have to think that one of the more frightening experiences, one of the more threatening experiences, is to doubt your perceptions.
Yes.
The most extreme version of that, one of the most extreme versions of that would be a psychotic illness like schizophrenia.
Right.
I so empathize with those who have difficulty distinguishing between their own perceptions and the perceptions that may be different of those around them, and trying to navigate that. How do you trust your own perceptions? But that's not the exclusive domain of schizophrenia. It happens, I think, to some degree for almost everyone. There's always an opportunity to question our perceptions in some way. Right. And that's a very, very threatening thing.
It can, especially people and these are people that you're treating too, that have suffered through PTSD, that are severely depressed, anxiety, and so on. And many times that is coming from psychological abuse, which if you're being gaslit, as an example, and this is fresh on my mind because I just interviewed someone who wrote a book about gaslighting, talk about altering your perceptions of reality and knowing that someone is doing that to you on purpose.
Oh, right. What a violation of trust.
Absolutely.
And, that's got to leave a mark.
So when you're working with a patient, let's take this winding road here for a second. You're working with a patient and they're coming in and they say, you've discovered working with them that yes, they suffer from PTSD, and it was and they're severely depressed. They want to try ketamine, and let's say there is psychological abuse heavily involved. How would a treatment plan, and I realize every person is unique, but a treatment plan for someone like this, that nothing else has worked to help them get out of the depression piece. That's still lingering, even with a lot of therapy and so on. And so they're like, ketamine, this is going to be the thing I'm going to try now. How would you start that process with someone?
That's a great question. And so to answer that, one thing that will probably be helpful to talk about first would be, how do we think ketamine works?
Right.
And because that will lead into how do we then best capitalize on what ketamine is doing in the brain, and because that informs the treatment plan. First of all, there are two different answers that I can give to that question. How does ketamine work? The first that I always need to give is the short and humble. And that would be, and because we're talking over the phone, you can't see this, that would be me making I don't know hands. I think that we always need to be humble about the things we think we know, because it necessarily is a small fraction of what is knowable.
Right.
But that said, I don't think that should be a cop-out for not trying to know everything that is at least known and trying to know more. And so with that said, there are many aspects to ketamine's mechanism. It has a very rich pharmacology. It goes a lot of places and does a lot of things. The primary focus, especially over the past decade, has been its effects on a system in the brain called the glutamate system. Glutamate is the most abundant neurotransmitter, chemical messenger in the brain. The ones that we tend to focus on, the ones that are more commonly known and the classical targets of antidepressants, are serotonin, norepinephrine, dopamine, but glutamate is the most abundant. Really, nothing happens in the brain without glutamate assisting in some way. And it's an important chemical involved both medicinally, but also in disease processes that probably go beyond the scope of this conversation. But suffice it to say, ketamine has potent effects in the glutamate system. There's some debate in the field as to exactly which aspect of that's important, because it affects a couple of glutamate receptors. But there is less debate about what happens a couple of steps down the road, which is that it enhances synaptic plasticity, that capacity of the brain to heal damaged connections, to form new connections, to reroute around areas of damage. And this is particularly important for depression or for PTSD, for chronic stress, because we now clearly know that these conditions take a structural toll on the brain over time. That there is a loss of the number, function, and quality of connections between certain areas of the brain, particularly some cortical and target limbic areas. Cortical being areas like the prefrontal cortex, which is involved in higher order thinking, planning, organization, and limbic areas, which are involved in emotion regulation, memory, etc. And so it looks like fairly quickly and a very effective, potent way, ketamine can produce what are called neurotrophic factors, these proteins that are involved in making these repairs, and particularly one called BDNF, brain-derived neurotrophic factor. Interestingly, one also that is enhanced by things like exercise. However, like I was saying earlier, it's not the only thing that ketamine does. It also has targets at some of those classical monoamine receptors, serotonin, norepinephrine. Interesting to me, it's also a potent anti-inflammatory and immune modulator, and the role of the inflammatory system, not just in mental health, but in all of health, is very promising. It also has some weak activity at the opiate receptor. It does a lot of things. And so with that in mind, if it is true that ketamine has these positive effects on the plasticity of the brain, then it would be very helpful to capitalize on that and to, within a window of time after ketamine administration, to pair it with something like talk therapy, with some kind of positive new learning. And maybe particularly with rapid skill acquisition types of therapy, like cognitive behavioral therapy, dialectical behavior therapy, etc., but also positive social interactions, focusing on healthy diet, healthy eating, other healthy life changes, exercise, etc. In the case of somebody like you mentioned, somebody who's had severe trauma, that should also specifically be a trauma-focused therapy, because it's not just a benign, easy thing to have ketamine.
Right.
It can be a difficult experience. It leads people to have a dissociative reaction, most people, and so that means a disconnected feeling. It can be a very strange experience. Now, fortunately, if somebody is well prepared for that and it's in a controlled medical setting, and we really monitor and control how stimulating the environment is, then it tends to be a very well-tolerated experience. But it can really open up a can of worms for somebody who's had trauma. And so just like you wouldn't just throw somebody into an intensive trauma therapy without other tools to be able to manage the feelings that come up and the experiences that come up during that treatment, in this case, we would want somebody to be working with a skilled trauma therapist who can help them navigate that experience. Even somebody who hasn't had trauma, I still think it's very important to pair this with talk therapy. If for no other reason, then any change is stressful, even good change.
Right.
And so if somebody has had a long-standing depression and all of a sudden they're feeling well, that can be really stressful, and it can be helpful to have somebody help you to acclimate to that.
Thank you so much for saying that, because that doesn't get said enough. I remember, I'm glad that I went through the experience, even though it didn't turn out very positive. It was another one of those things, though. It happened and I learned from it. I made lemonade out of lemons. I did a week-long intensive brain training work with totally unqualified people, did not have a therapist on staff. And a lot, 5 hours or 6 hours a day of doing that is intense for anyone. And there was no one there to catch the emotions that come out from those kinds of experiences where you're actually changing neural pathways. And that I learned from that, and I raked them over the coals. You should not be doing this without a licensed therapist here to help your patients through this process. It is completely unethical that you're not doing that. And I don't know whether they ever listened to me on that or not. I took their shows that we did off the air because I was so mortified. I know what I went through during that experience, and it was I needed someone there to help guide me through all of those emotions that come up, because you're right. Even good change, good things came out of it. Believe me, good things came out of that experience in terms of my brain functioning faster and certain things being healed and so on. But when you're someone who's been depressed for a very long time and you all of a sudden are feeling a relief from that in a completely new way, that is exceedingly stressful if you don't have someone holding your hand through that process. It is, even if you have someone holding your hand, but boy, does it make the difference when you do.
Absolutely. And, by definition, if you have depression, then it's having a significant impact, and there are consequences in your social and occupational functioning. And so somebody who's had a long-standing chronic depression, their life is typically going to reflect that. You may have lost some of the support network and family or friends. Occupationally, you may not be where you would have been otherwise. Life can be in disarray. And so, an analogy I use sometimes is, it's like a poorly prepared survivalist crawling out of his bunker after the nuclear apocalypse and looking around and saying, well, great, I survived, but now what?
Yeah, exactly. This deserves further exploration, and I know we're at time now, so I hope you'll come back on again, because this whole conversation took a very interesting turn, and I'd like it to continue on another show if you're open to it.
Oh, I'd love to. Thank you. Yeah, any conversation with me is probably going to take some twists and turns. I'm sorry.
Same here. No, don't apologize. I'm known for this. Sometimes our editors are like, the first part of the show, I was with you, and then you went way somewhere else, and it was just as interesting, but we should cut this in half and make it two separate. But it's psychology. What could be more fascinating than that's the mind. It takes you so many places. But anyway, thank you for coming on, and please tell our listeners where they can find out more about you.
Oh, great. They can come to our website, which is actifyneuro.com, actifyneuro.com. We are on Twitter at Actify Neuro. We're on Facebook. We're around. So please come to our website. We've got a lot of information on there, and we'd be happy to talk with anybody who's interested further.
Okay, fantastic. Well, you're going to stay on. We're going to chat for a minute after, but I want to say thank you so much for coming on the show.
Thank you, Kristen. I really appreciate it. This has been fun.
Yeah, and thanks to our listeners for another windy road on Mental Health News Radio.
But never without good intentions. I heat up and act on my emotions.
Thanks so much for listening to Mental Health News Radio. Our podcast can be found on iTunes, Stitcher, and hundreds of other podcast apps, or you can visit our website at mentalhealthnewsradio.com. If you have a question or would like to be a guest, become a podcaster on our network, or join the amazing organizations that help keep us on the air, please email us at info@mhnrnetwork.com. Get ready for that special goodbye from our resident therapy dog, Miles, and a special thanks to Emily Sohn for letting us use her incredible song, Cordial, for our podcast music. Listen to the full song on SoundCloud at emily.sonne.
Don't be surprised when I don't hate on you. After all, we promised we'd be cordial. Sometimes in you I can fight it.
Good boy.